key feature is that the prevalence of breast cancer in a screening group is quite low. We're talking about, let's say, 1 in 100. So the radiologist is reading 100 cases and may find one cancer. And so that means with clinical audit, reviewing the cases read, it takes a long while to build up a critical number of cancers to assess performance. So what we've done, we've contracted the real life environment. So instead of having 1 cancer per 100 cases, we will have, say, 20 cases per 100 cases. And moreover, they don't need to wait for 1 or 2 years to collect the data on that reading performance. They get the data and the feedback on their performance instantly. It's also very important that a service who is running a screening program knows how their radiologists as a group and individually are performing. So it can be used for the individual feedback on performance. It can be used for the whole service feedback and performance. And then it can be used for comparison amongst peers and comparisons of performance amongst different services. The key is that any radiologist anywhere in the world is able to access the test sets, and on completion of the test sets obtain immediate feedback on performance. The radiologists and the non-radiologist screen readers are very keen to get feedback on their performance, and it is very satisfying once you have done the breast program to see what you're doing, to see what areas you can improve in, and see that you are reaching the benchmarks that are required for a screen reader.
Screening's quite a challenge for a radiologist in many ways because you have to see a lot of images to actually find an abnormality, certainly an abnormality that matters like a cancer. You don't get the feedback on whether you got the cases right or not for quite some time because, as you know, the issue is that the cases that you recall, most of the cases that you recall are going to turn out to be okay. They're actually not going to turn out to be cancer. And identifying which ones are malignant and which ones are just look suspicious initially but turn out to be okay, the feedback on that can take a long time. So from a radiology point of view, it's a little difficult to improve your skills because you have to wait for that feedback. One of the challenges is the overlap between benign and malignant in breast imaging in particular. And so what we're hoping is test sets that will address a particular lesion type, particular lesion appearance, and maybe a particular area of need. And so we'd like to address that by trying to make sure that people call back what matters and don't call back what doesn't matter. And clearly that's a skill that we develop over time, but being able to concentrate the teaching material to show you what does and doesn't matter and what you might be recalling that doesn't need to be recalled is a very valuable tool, something that you can get out of the test sets by seeing why you're recalling things that turn out to be considered benign or normal in fact. Yeah, I think the breast program has helped a lot because in a way it's giving you that rather immediate feedback, isn't it? It's collecting a lot of the cases that would have taken you a long time to find or to see. There's also the issue, isn't there, of going over the cases, and because the abnormality is marked on the cases and what you recalled is also marked on the cases, you can study in more detail what it is that you got right and wrong. And so it's useful to be able to compare your findings with what is the truth, and also to try and work out why it is that you did or didn't get that case right.
So my main aim with my work is to look at improving the detection of cancer. The focus has been on breast, but we're actually looking at breast and lung at the moment. Breast has been around for around 7 years, and really there are, if you like, two arms to breast. One is about the research, and the other is about improving detection in the clinic. And certainly over the last 7 years, what has happened is that we have produced a product that engages with the clinicians. It's engaged so far with 90% of the relevant breast imaging clinicians in Australia and New Zealand. And we've shown that it actually improves detection of disease by about 34%. So people who engage with breast, when you look at subsequent scores within the breast program, they seem to get better. At the University of Sydney, and in collaboration with world experts everywhere, such as Harvard University, University of Melbourne, University of California and so on, we've been working closely to look at innovative ways to improve cancer detection. In particular, I can give you a number of examples, but I suppose key examples would be about improving the risk predictions that currently exist around breast cancer. We're also looking at new methods of imaging. We were the first in Australia, for example, to explore the impact of digital breast tomosynthesis on breast detection, and currently we're looking at a brand new method of using X-rays called phase contrast imaging. In fact, the world first clinical trial on phase contrast CT will occur in Australia, and it will be led by our group. In terms of improving things in the clinic, one of our focuses is on the developing world and low to middle income countries. Because what we find is, and we have shown this, again breast has allowed us to do this, we've actually gone into a number of countries worldwide and we've explored diagnostic efficacy amongst the individuals diagnosing breast images in their country. And we find that very, very often that the level of diagnostic efficacy in these developing or low to middle income countries is much lower than it is perhaps in Australia or elsewhere. I know that through programs like breast we can transform that, but I know the biggest effect that we can make is through education. And what breast does, it's an interactive, reflective, educational tool that we've proven it improves things, and we know we can make a profound difference internationally if we can provide the infrastructures to go into those countries and allow breast to be present in everyone's clinic. We can say with certainty that our products are unique, that nobody else offers our products. And the reason why not is that we have managed to blend scientists, the best scientists, with the best clinicians. We have people that are an integral part of what we do who set up breast screening in Australia and Southeast Asia, for example. And it's that sort of synergy between these two groups of people that make sure that we have the best images and the best products for every clinician. Very, very easy. Just send us an email and then we set up a system that allows you to access the data. We enter into an agreement with your university or your institution or whatever, and we are delighted. The more people who use our data, the better.